Now let me turn to introduce our closing keynote speaker, Elizabeth Mitchell, who is well known to many of you. She's the president and CEO of the Pacific Business Group on Health. And Elizabeth has had so many important leadership roles, both in the public and the private sector, working for a health plan, working in the state legislature in Maine. She's also served as president and CEO of the Network for Regional Healthcare Improvement and CEO of Maine's Business Coalition. So she comes to her current job with so many experiences and really understanding how the various sectors view healthcare. I was really excited to look at the Pacific Business Group on Health's website and to see that they have 3 strategic focus areas: advanced primary care, functional markets, and purchasing value. And so we can really see that Elizabeth and her organization are primary care champions. We're very excited to hear from Elizabeth today, and I will be moderating the Q&A, so please chat your questions in. And let me now turn the baton to you.
Thank you so much, Anne, and thank you to all of you who are working to make people's lives better in the community, in your practices. I am absolutely honored to be here today to celebrate your work, to thank you for everything that you are doing, and to really share with you that I believe we are 100% aligned. As Anne shared a little bit of my background, I have had sort of an unhealthy obsession with trying to fix the healthcare system. Over 25 years, multiple different roles. And I am 100% convinced across all of those experiences that primary care is the foundation to a high value, high functioning system that meets the needs of people and communities. So I could not be more pleased to be here and to share what I believe is a truly exciting opportunity to work more closely across employers who pay for care and to the clinicians who are actively and working with our employees and with communities in which we work and live. So if you go to the next slide. As Anne mentioned, I'm representing the Pacific Business Group on Health. We have about 40 members who are jumbo employers. We are purchaser only. We do include public purchasers like CalPERS and Washington Healthcare Authority, but our members include very large private companies like Boeing and Walmart and Costco. And they are truly invested in this work because they are paying for care on behalf of over 15 million Americans. And they want their employees to be healthy. So I am absolutely sure that primary care physicians and large employers want the same thing. Healthy employees are healthy patients. And we know that employers have to play a role in making that possible. We want to own how can we be the best partners to primary care practices to make it possible to deliver optimal care. And Anne mentioned that our 3 priority areas of work are advanced primary care and quality, and we're going to be talking about that today. Also, affordability and value. We absolutely have to address that because we simply can't sustain the cost trajectory that we're on. And functional markets, because right now we know they are not functional, and we believe that that makes it harder for us to, frankly, support physicians and care teams in the way that we would like. And something that I am sort of embarrassed to say we had not added sooner, but our board voted to add explicitly in the last several months, was a focus on equity. It is long overdue. We recognize that we are learners in this space, so we are learning from and with you and others how to best promote and support equity, but that is another of our key strategic priorities, and we are grateful for those of you who have gone first, and we will look forward to partnering and learning with you. Next slide. So as you probably know, and I think one of the themes of this conference is that COVID is really only exposing what I call the system's pre-existing conditions. we have had problems in the healthcare system for decades, certainly since I've been working on it, and they are simply being exaggerated, accelerated, exposed in ways that are really forcing action that, in my view, is long overdue. We know that the US healthcare system really is too expensive and does not produce the outcomes that it should. We know that the primary care foundation, on which we should have invested fully in, is really weak, and that is being exposed during this pandemic, and we will talk more about that. We also know that the outcomes are not only uneven, health equity is a major challenge, but also that they are not good enough for the patients and the employees that we are working on behalf of. And frankly, the payment system, the fee-for-service system has failed us. That has also become particularly clear during this pandemic, where we are starting to see evidence that practices that were paid on a prospective population basis are actually faring better. They are stronger, more resilient. They are able to meet their patients' needs in a changing environment. So we really need to learn from this and figure out, how do we just finally get off this fee-for-service chassis and move forward to what we all know will enable better care. So changing the payment system, changing the payment model is truly a priority of ours. And we have enlisted our employers in really helping us to drive that change. Next slide. So this is an old slide, but I think it is also even more relevant during a pandemic, when we see that the healthcare costs are actually coming out of what we know make people healthy. And it is only getting worse. If you see the graph on the right, 121% increase since 1999 in premiums. It just keeps going up, regardless of ability to pay, regardless of family circumstances, regardless of value for that payment. But even more importantly, it's taking away from social determinants, which we know is what helps keep our families healthy. So transportation, food, all of the things that we rely on to actually be healthy, we are losing out because so much of that money is going into healthcare. So we have got to rethink how we pay for care. Next slide. So as I said, employers and physicians want the same things. They want high quality care that enables healthy and productive employees. And as I mentioned, they are paying those bills. And that money could be going to their core business, to wages, to research and development, to jobs. That has become particularly acute in the pandemic, where our members are also facing significant financial pressure. They want to be good stewards of their resources and make sure that what they are paying for actually promotes health and well-being. And employers want to alleviate the burden on clinical teams. They want to remove the barriers that their payment systems put on you to make it harder to provide better care. And employers, frankly, want much more direct partnerships with physicians and care teams. They want to learn from you, how can they be better partners, and how can they make your jobs easier to do the very important work that you're doing? And COVID, again, in this remarkable environment of significant financial pressure and obviously pressure on people's health and well-being, it has removed long-standing discomfort on the part of employers from making really significant changes to their benefits, to their payments, and to the network design. There has always been sort of a cautiousness. They don't want to be disruptive to employees, but we're past the point of disruption. And right now they are looking to do things that really reflect, how do they pay for the highest value care and how do they change the current system? Next slide. So as I mentioned, we are on a path to help you to partner to change the status quo. Next slide. Something that I really want to sort of underscore, it would be incorrect to suggest that employers want to pay more for the same old thing. They have been told for decades now. I really think of it as like Charlie Brown with the football. Lucy, it's like, come on, try again. They have been told that if you just pay more for this, quality will go up and costs will come down. Well, they're really, they've become quite skeptical about that premise. However, primary care is a very important exception to that. So one of the things that I really want to to share is our work with primary care practices in California. We run something called the California Quality Collaborative. It is a regional multi-stakeholder entity that works directly with practices and plans and physicians and clinicians and care teams to really understand how to change care at the practice level. And we had a federal grant to work very closely with small and rural practices to help them change care. And these are some of the results over 5 years. We also partnered with other regional health plans. There was over $345 million of savings, and that is important. But what was far more important was that those savings occurred because care was better, because quality was improved. So there were over 67,000 avoided ED visits. There were over 59,000 avoided hospital admissions, which truly prove to our employer members that better care does cost less and that investing in primary care is absolutely the right way to go. And I'm going to quote the inimitable Lance Lang, who you probably all know and love. He says that the California Quality Collaborative helps us build the system that we would be proud to buy as employers. And that couldn't be more true. That partnership, understanding what physicians need, and then playing the role as purchasers to make sure those needs are met is really how I believe we are going to transform care and payment. Next slide. I had the privilege also of listening to the opening keynote, and I heard a comment about Walmart and some of the other employer disruptors really making providers uncomfortable. This is probably another example of that, not necessarily primary care, but specialty care. But I really want to underscore some of the results of this. And these are results from the that were quantified by the Harvard Business Review that showed that by using a center of excellence model, by selecting the highest value partners and partnering directly with these surgeons and the facilities where they work, we achieved remarkably better outcomes. Over 50% of unnecessary surgeries were avoided. Readmissions were avoided, again, proving that better care does cost less and underscoring for employers that by going direct, partnering directly with the providers, understanding their barriers and really addressing them, they were able to achieve better outcomes and better experience at lower cost. So this might be one of those uncomfortable disruptions. PBGH was part of scaling this program over the last 8 years, and we were able to really see results across the country. But this is the type of partnership that in our mind shows that we can do this together, that we can put patients first, change care, change payment, and have better results for all involved. I also want to just say about this program that once a year, we would bring all of the physicians together to have them share their experience about what it was like to work in this program, because this is really different. And I actually was in a room listening to neurosurgeons who had taken time out of their practice talk about how it was so important to them to publicly and transparently report their patient-reported outcome measure results because it helped them get better. We believe that if we engage providers directly in the quality work, that there will be a win-win. So again, this is just an example of employers rolling their sleeves up, getting in there and partnering with physicians to make care better. And we look forward to doing more of that. Next slide. So as I said, COVID-19 is an accelerant. And at the next slide, I just wanted to underscore that employers who have been paying these bills and absorbing the increasing costs are under enormous financial pressure. There are obviously some examples of employers who are doing well in the pandemic, but when you think of manufacturers, of many of our members, or the Disneys of the world, who I can quote because this is all public information, they are having significant layoffs, significant threats to their core business. And they are having to be far more assertive and innovative in how they partner and how they pay for care. They cannot tolerate the waste that has been in their healthcare purchasing anymore. And whether that's an ineffective drug in their formulary or working with a low quality provider, they are looking at things differently and much more urgently because they have to. I believe this is an opportunity for new kinds of partnerships. Next slide. And as we have talked about, we know that primary care is in crisis. PBGH has been talking to our employer members about this from the very beginning of the pandemic. We have been working with CMS. We have been working directly with providers, with other physician groups to try to understand how we can collectively address this. We think this is absolutely urgent, and we are doing everything that we know how to do and want to partner with you to do more. Next slide. And the other sort of the flip side of this crisis is that we know that as these primary care practices are vulnerable, as they are facing true financial pressure, that actually could lead the way to more consolidation among the large systems, sort of buying up fragile practices. And we also know that that is not in our collective interest. We know from the research that consolidation of big systems does not improve quality. It certainly does not improve patient experience, and it does drive up prices. So this is not something that we hope to see. And we believe, again, that strengthening primary care, that investing in robust primary care will also avoid further consolidation and further harm to the system, because we do not want to come out of this pandemic with a more expensive, lower value system than we went in with. So we are actively involved in trying to ensure that resources go to primary care and maintain that healthy, independent foundation. Next slide. So what are we doing about it? This is a lot of talk. We want to ensure that we are trying to truly step up and make a difference. Next slide. So a couple of the things that we've done, and again, I know I heard your policy segment. I know how active you are on the policy front. A couple of the things that we have done, we held an online Hill briefing. We partnered with AAFP and Pepsi to actually go directly to Congress and say, you know, it's great that you gave $130 billion to the hospitals. Obviously, they need it. We want providers to have the care they need, but it has to go to physicians, to primary care physicians, to practices and care teams in the community, because that's where people are needing to get their care. So we had terrific attendance. Not sure we had a lot of impact, but we have certainly raised the issues, and forcefully so. We also held a roundtable with Secretary Azar to talk about what is the impact of the pandemic on primary care? How is telehealth being used, scaled, and what are the barriers? What's happening with deferred care, and why do we need prospective population-based payment models? So we are certainly doing our part to try to advocate on behalf of primary care practices. Next slide. Something else we're doing, we have actually launched something called the Health Plan Playbook. We're actually going to be calling it the Health Purchaser Playbook, to collectively send a signal to the market about what purchasers care about. And over 30 of our members, that's 30 jumbo employers representing, you know, over 10 million Americans, have signed on and asked us to do this on their behalf. And one of the things in 2020 that they prioritized was understanding primary care spend. And what you will see here is that it is far too low. We know that in European countries with robust primary care systems, they typically spend about 14% at least. So not only is there a significant range, but even the top of the range is too low. I do also know that there is going to be more work released on this from IHA and Cover California and others who are really digging in to understand how can we improve investment in primary care. And frankly, what are the outcomes when we do that? Again, our PTI results showed clearly that investment in primary care leads to better outcomes. We need to continue to quantify that and demonstrate that and build the evidence base, because we have got to drive this change. Next slide. This, to me, if you have one takeaway from this talk, I think this really exemplifies the disconnect that we have been living with for so many years, and one that I hope that we start to overcome starting now. We surveyed our jumbo employer members about whether or not they think payment reform for primary care is important. We have shared with them, as I mentioned, what's happening to primary care practices in the pandemic. And we've shared the challenge and the burden of the fee-for-service system. And we asked them, how important do you think it is to support payment reform? You will see here that 90% said it was very important. The remaining 10% said it was important. I think that's a pretty ringing endorsement of the need for change on behalf of our members. So we followed up with a question. So what are the barriers? If you believe that this is very important, why isn't it happening? I think these answers are very telling. I think they create a roadmap for what we need to do next. The barriers that they stated are that their health plans are either unwilling or technically unable to implement. And I don't know if that is true, but that is their perception. They are unsure of what are the payment models that are most effective. What payment models should they adopt? And I think that really goes to a point that I think is so important to understand. Purchasing healthcare is not an employer's day job, right? That is not necessarily a core competency for them to understand different incentives and different payment models. They need to partner with plans and providers and others to really understand what payment model will achieve the aims. So they are unsure of which models are best. And then they're unclear about how to implement a new model. This slide to me underscores the opportunity that we all have. These are all barriers that can be overcome. We believe that this is technically possible to do. I've been part of pilots that do it. We can help come to consensus on best payment models, and we can certainly help with implementation. And frankly, we can share the lessons that already exist. I think this is actually an incredibly encouraging result because these are things that we can do something about. Next slide. So employer perspectives, what should primary care look like? They know that it needs to be team-based. They know that it needs to be focused on population health. They absolutely prioritize patient engagement, patient experience. They know that it needs to be integrated with behavioral health. And I will say, when I first took on this role over 1.5 years ago, I sat down with all of my members, or most of my members, and every single one said that one of their top priorities was addressing behavioral health. They did not believe it was being adequately addressed. They know it's important. They don't know how best to do that, but they believe that integrating it into primary care is a critical strategy. They also want increased access and alternative visits like telehealth, like home-based visits, like community-based care, obviously connected to community and social needs, and accountability for total cost of care. Remember, they don't want to pay more for the same old thing. They want to pay more for care that really achieves the outcomes and reduces unnecessary spending. Next slide. So what I am so honored and really thrilled to share is that all of the principles that we know that the Primary Care Collaborative has endorsed and promoted over the last several years actually line up perfectly with what employers want to see from the healthcare system. And frankly, this shouldn't necessarily be a surprise because, as I said, we want the same things, but we have actually quantified that now. We know that we are working for the exact same goals. I will say personally, I believe that this grid right here actually is a pretty significant understatement of alignment. For example, I will assure you that employers support enhanced access for patients that is comprehensive and equitable. I believe this is just the bare minimum of where we align. I think that the alignment is actually thorough. I think that we are absolutely going in the same direction. And I think this shared principles, these attributes of primary care that we all agree to, are the foundation of our work together and where we can go next. I think this is one of the most positive things to come out of the pandemic. We are working together in new and important ways. And I truly believe that together, in partnership, we can change care and payment and truly make a better care system for patients. I want to just take a second here because all of these attributes, as important as they are, I think they boil down to one thing, and that is better care. I had the real privilege of working with one of my heroes, Lisa Letourneau, and I'm really hoping she is on today. And about 20 years ago, she designed a care management program. We put it together with what she said, duct tape and bubble gum, but we are from Maine, and this was pre-EHR, this was pre any bells and whistles, and it was about how do we change care and outcomes for chronically ill patients. And what it was, we built up a care team, it was all under her leadership, that actually went to people's homes, went to the hospital. They went to their work site if they needed to. And they actually engaged people in changing their own health outcomes. This was out of the box. It was creative payment methods, but it truly engaged people and met them where they were. And one of our colleagues, Dr. Larry Anderson, I asked him, why do you think this works? And he said, what works is when patients have the epiphany that someone actually cares about them. And that's what we're talking about here. All of these attributes are truly just ways of showing that we care for the people involved. We care about their health. We care about their well-being across all dimensions. And what we need to do is just eliminate the barriers in the system that make it so hard to do that. So I am, again, thrilled to be in such good company with PCC, the National Alliance, and all of our members, and say that I think we are very well positioned moving forward to truly do some transformational work. Next slide. So what's next? The way forward. Well, it's not enough, as I said, just to talk about this. We are thrilled that we are actually getting significant traction to actually start using these attributes. And California Quality Collaborative and PBGH have actually also been working on a measure set for advanced primary care because, quite frankly, our members said, great, we know that these are what we want to pay for. How do we identify the practices and pay them differently? So there's a very practical need to show the measures, to show the outcomes so that we can partner effectively. And I am really excited to say that at least 2 major California purchasers are looking to incorporate those measures into their contracting for 2022. I'm not going to steal their thunder. I think you may be hearing from them in the next few days. But again, we are putting ideas into action. And I think that this could be a major catalyst for changing California. And again, we want to share this nationally. We want to scale. We want to truly make this happen faster. So we will be learning together and sharing that with you. Next slide. Something else that we are working on is a national payment reform work group. We've got our members. We're partnering with physician groups and broader unions and employers, and we want national health plans to partner in this work to change care and payment. We are eagerly looking for partners, particularly among health plans in this work. Next slide. And as I said at the very beginning, we know we have to step up and address inequities, systemic racism. We know that is on us. Some of our members are making very significant contributions and commitments, financial and otherwise, to truly take action on equity. We are far too late to this game. And we will be learning from those of you who have been doing this. The Medicaid plans, we've already heard from some. They said, we have been looking at inequities for decades. So let's learn together. We are evaluating our benefits. We are going to be looking at our measures. We're going to be really figuring out how primary care can lead us through a much more equitable system. Next slide. And finally, sadly, these are not real headlines, but we believe that they are achievable headlines. We would love to see the day where, the head of the New York Times is saying, hospital quality standards rise because of the market, or healthcare spending is down and that money is going back into families, into wages, into, food, transportation, whatever it is that families need, and their discretionary income rises because their medical bills are reduced. So again, we believe that this is all achievable. We know that no one can do this on their own. And I will just say on behalf of our members that we are ready to own our part of this partnership, to step up and to work with you to truly achieve what I believe are shared goals. That's it. Thank you so much. I'm hoping that there are questions.
Thank you so much, Elizabeth, for your remarks. And now I'm going to moderate some Q&A from the chat. Please don't be shy. A number of questions have come in and we can accommodate many. Let me kick off by just reflecting that there truly is so much alignment between our two organizations, and we are really excited to partner with you and other colleagues to move our collective agenda forward. So those were great remarks, and so exciting to see how the employer community, under your leadership, under Mike Thompson's leadership at the National Alliance, are redoubling efforts around primary care. One thing that you noted is that our barriers are surmountable, and I completely agree with you. I think it's more a question of will than, that there are technical issues in our way. One of the first things you mentioned was the employer sense that health plans maybe are unwilling or unable to change. And since you worked at a health plan, I'm wondering if you have any insight there. Of course, there's a variety of health plans across the country. Many are already moving in this direction. We have lots of examples, but that was a finding from your employer survey. And so I'm wondering if you might reflect on that a bit.
Sure. And I do want to underscore that that was the employer's perception. So I'm not speaking to the truth of it, or it is certainly something that is perceived. I believe it is, there are a lot of health plan leaders who want to change primary care payment. I have absolutely no doubt about that. I believe it is difficult to do. And in part, it's for some really not very exciting reasons, like legacy claim systems that really don't change very easily to do prospective payments. There are barriers to data sharing that simply have not been overcome. And frankly, to do population health management effectively, particularly around behavioral health, you've got to be able to see all of the data. Right now, that still doesn't happen in too many cases. So there are some just infrastructure problems that we really do need to overcome. I think that there has also been some lack of clarity from purchasers who may not have effectively articulated what they wanted to see. So it hasn't been as clear as it might need to be that they want these changes made. So again, I believe that there are a lot of health plan partners out there who want to do this. Frankly, employers can't do this without health plan partnership. They rely on their plans to implement these changes. So again, in our primary care payment reform work group, what we would like to do is get alignment among employers to share that alignment with the plans. So they're not responding to confusing messages. And then hopefully that will also translate to alignment across payment platforms for providers. I worked on the provider side. I know you can't respond to 10 or 20 different programs. You just can't. And, chasing a slightly different new denominator for diabetes measurement is not a good use of time. So we need to align. We need to send shared signals across our highest priorities. And I think collectively we can do that.
Thank you. Two reflections on your remarks, Elizabeth. I mean, both this notion of investing more and understanding what is currently happening with respect to investment. And I appreciate you making the point that, now you understand that there are differences in how health plans are investing. And you want to go further to understand what are the implications of those investments, because, in and of itself, how much you're investing is sort of a so what. I mean, what difference does it make in terms of important patient outcomes? So applaud your effort to do that. That's very, very exciting. And we'll look forward to understanding what you learn, because I think we need a lot more research in this area to really understand the implications of this vast variance in terms of investment. I think what's also exciting is that in the attributes, our shared attributes of what we want from practices between the Pacific Business Group on Health, PCC, and the National Alliance, payment reform is one of those 7. And so, I mean, that makes it front and center that we think about investing more in primary care and paying primary care differently in order to get to that value. And so it's not, just a one punch, it's a 1-2 punch for us to actually get there. Really, really exciting. What have you seen in terms of behavioral health integration in the practices that you all work with? Because that's also, as you mentioned, so important to employers. And again, it's one of those 7 attributes.
Yeah, as I said, it is a top priority for employers. I also think we have a really long way to go in a lot of practices. Again, I can't speak for them. I'm not a clinician. I don't want to do anyone a disservice, but I will say that in our work with primary care practices, we know it's doable, but right now they're not resourced for it. There's often not enough clinicians to even hire. And frankly, there are some systemic barriers like carve-outs and where they are separated through administrative requirements, or again, going back to lack of data sharing. It is not easy to overcome those systemic barriers to truly build comprehensive care, whole person care for patients. But we do know it's possible. And, we're seeing some exciting results out of some integrated systems, Kaiser being an example, or Intermountain. But how do we take those lessons and share them with independent practices, rural practices? I think telehealth is going to be a big part of this. I think in California, anyway, there's like an inverse relationship between need and availability of mental health providers. LA, you've got all sorts of them, but what about these rural areas? So we believe that telemedicine, telepsychiatry will be part of this. And again, we've got to overcome those systemic barriers to expanding access. But that will be a big focus of the California Quality Collaborative's work in 2021.
Thank you. Here's a question from Howard Haft, who leads a lot of important primary care work for the state of Maryland. We often hear payers say that they want to change payment methods, but they cannot because of their large number of ERISA clients who are demanding evidence. So show us the evidence, then we'll consider change. Yet when we talk to the employers, they seem to be aligned with payment reform. So his question is, where is the disconnect?
I think that is the opportunity. I think that the disconnect is far less than we may have come to believe. I think that, as I've said over and over, employers and particularly primary care providers want the same thing. We need to have direct conversations so that we better understand that. We led a process through the California Quality Collaborative over the last year where we talked directly to physicians. What were their barriers to change? It all came down to payment. And when we talk to our employers, they want to change payment. So we've got to just get over this idea that we are not aligned and create tables where we can have those conversations. That's what we want our primary care work group to do. We believe that we can have rapid progress once that happens.
Well, and also you mentioned that we really need to understand what are the effective models, and then, how do we go about implementing them? We know if the attributes of primary care, which are articulated in that lovely chart, how would we know if we were achieving them? So how are you going about getting consensus in terms of the primary care metrics?
Sure. And as you know, Anne, I was on the National Quality Forum board for a long time. We got to work together there. I was on the National Academy of Medicine core measures study group. So I've spent a lot of time looking at measures and measure alignment. Frankly, I think there are plenty of measures out there to choose from. I don't think this is necessarily a matter of, inventing new ones. I think we have certainly robust enough measures to start. PBGH actually has, in-house measurement experts. We are actually measure developers for CMS. So we really have had the opportunity to test and pilot some robust patient-reported outcome measures. We know they work. barriers have been adoption by the industry and frankly, data collection. We have got to just say it's time to move past that. So in our work to get alignment in California around measures, we have set some key criteria. We know that they are aspirational. That is intentional. They must they must align for implementation. And we need them. We know they have to be actionable for providers. They need to give meaningful information back to care teams. Otherwise, it's sort of a waste of time. And frankly, they have to be based on outcomes and patient experience. So for example, we are including a depression remission measure. It's not just were you screened, it's has there been remission? What is the outcome for the patient? And ED visits is another example. It's not enough to know, was everything done? Did you actually avoid an emergency room visit because you got the right care at the right time in the right setting? So we are absolutely prioritizing outcome measures and experience and safety. And we are working with purchasers, as I mentioned, across California to really think about how do you pilot these. We're also working with providers. We are trying to bring everyone together with the plans to say, how can we move this forward? And I know that we will be working with you on that because it's going to take all of us. And we really believe there's an opportunity here because our members want to pay differently, but they've got to see those outcomes to know how to do that.
Absolutely. And as you and I know, if we wait for the measures to be perfect, we'll be waiting another decade. So, we're so much further ahead than we were 10 years ago. And I think the question is selecting amongst many measures, the ones that really are the best. And you've just laid out some great candidates. So hats off to you. This is a question from Mark Del Monte, who's the president and CEO of the American Academy of Pediatrics. He's wondering what you're seeing with everybody teleworking, washing their hands constantly, wearing masks. Are you seeing utilization among employees of healthcare services go down? I mean, what any comments there, and what's in store on that front for 2021?
Yeah, I don't have any definitive data, but I will tell you that sort of our member representatives are sort of on the front lines, obviously different front lines, but of helping people try to stay healthy in this totally new environment, and new policies like new PTO policies, new telework policies, new safety standards in the workplace. What screenings, vaccines, they are absolutely part of the team approach to making this work. I will certainly say that elective procedures have gone down like everywhere else. We're certainly seeing that. I think that there is real concern about whether or not preventive visits are going down. They are very worried about that. Childhood vaccinations, where are those going to happen if people can't go in? So I wish I had data on this, but I will tell you anecdotally, we are absolutely hearing that from our members, and they want to know, how best to address that. Again, that's part of the partnership opportunity.
Sure. Are you seeing any purchasers developing incentives to support immunization, getting preventive services, better chronic care management?
Absolutely.
We'd love to get a little insight into what those incentives look like.
Sure. And again, remember, our members are the biggest employers in the country. And so it's different from some of the small and medium-sized businesses who are, often very innovative, but they don't have the same resources. But, as your initial keynote noted, a lot of our members are actually standing up their own primary care clinics when other options are not available. And, Disney is an example of that. Walmart is an example of that, and others. And they are intended to be much more holistic. They include mental health, they include dental care, they include, nutrition even. So they are looking at other models to deliver that care themselves. But again, I want to underscore, they are not doing that to displace anyone in the system. They are doing that when the system is not meeting their employees' needs. They would prefer to partner and ensure that those resources are available across communities. Again, they are trying to be leaders and innovators, but also partners, and would bring that to whatever communities they can. And to your question about incentives, they have great coverage. Our members have great coverage for preventive care typically. I can't speak to all of them, but they are absolutely incenting, preventive visits, well child visits, all of that they know that that's a part of their strategy to keep people healthy.
Thank you, Elizabeth. This has been a remarkable conversation. I really want to applaud your leadership. I'm very excited. I think we all are to be working with you much more closely. And I think, this notion of primary care, it's been so resilient over the last 10 months. I mean, there's been a lot of sucker punches, but primary care has continued to innovate. And now, we want to partner with folks like you, to invest more in primary care and really to change the way primary care is paid so we can deliver on those beautiful shared principles. So thank you so much for your remarks. Look forward to our work ahead. And now I'm going to close out the conference.
Thank you so much. We've got a lot to do together.